I apologize for the what may be an in and out voice this evening. Of course, laryngitis strikes at the worst possible time, and it happened today. But in any case, I'd like to talk a little bit today about, or this evening, about hormones and healthy bones and osteoporosis, address how it happens, when it happens, what we should be doing to prevent it, and then if diagnosed, our treatment options, and then some of the controversies involving treatment of osteoporosis. So I'll leave plenty of time at the end for questions. Please feel free to kind of, put those together for me so that we can address them at the end. So I'd like to discuss tonight why bone health is important, what osteoporosis is and how it occurs, how do we diagnose osteoporosis, what we can do to prevent it, and what our treatment options are. Why is bone health important? One, osteoporosis is very common, and we know this based on just how much research and development pharmaceutical companies are putting into it. There are many people affected. It's very serious insofar as it can lead to downstream effects that are very negative should a fracture occur. And it's costly. It can also sneak up on you. It's certainly a silent disease until a fracture actually occurs. How common is it? So what is it? It's a condition where the bones become weak and can break more easily. 10 million Americans already have the disease, and 34 million are at risk. Estimates suggest that half of all women older than 50 will break a bone due to osteoporosis, and up to 1 in 4 men will also break a bone due to osteoporosis. It is, the effects of bone are shown here. It ultimately leads to a decrease in bone quantity and bone quality. Now, what can we measure? And we'll talk more about DEXA scans in a bit, but we can measure bone quantity, the density of bone. You can see there a difference between the normal bone and the osteoporotic bone. We can't measure bone quality. So there is a possibility that the quantity can be decreased, but that the quality can still be very good. But the quality is not something that we right now have a tool to assess. Osteoporosis, generally speaking, is caused by old bone tissue being broken down too quickly and new bone tissue not being formed quickly enough. So there's a mismatch. Old bone broken down, new bone not formed quickly enough to replace the old bone. So what is the threat? Approximately, as we mentioned before, 10 million women over the age of 50 have osteoporosis. 34 million people over the age of 50 have low bone mass. And I call it low bone mass. What I'm referring here is to that, to what we semantically call osteopenia. Now that may or may not remain in the lexicon because truly it's not a disease state. Osteopenia is not a disease state, but it is low bone mass compared to a normal adult bone mass. The truth is that osteoporosis is a scary prospect. 1 in 2 women over the age of 50 will have an osteoporosis-related fracture. And due to the fact that our population is rapidly aging, the number expected to be affected by osteoporosis will increase to 61 million people by the year 2020. 68% of those affected are women, although 2 million men are at risk as well. So as far as the condition of osteoporosis, it's certainly serious. Broken bones occur in osteoporosis and are most likely to occur in the hip, the spine, and the wrist, although other bones can break as well. And what's the effect of broken bones? They can certainly cause severe pain. They may make you lose height, especially if those fractures occur in the spine. It may keep you from getting around and enjoying a good quality of life. And last but not least, unfortunately, osteoporotic fractures can result in death. 20% of seniors who break a hip will die within 1 year from problems related to that hip. And of folks who survive an accident like that, it can result in needing long-term nursing home care, which certainly decreases quality of life. Last but not least, osteoporosis is actually this isn't last, but in any case, osteoporosis is certainly costly. In 2005, it was estimated that an estimated 2 million fractures cost about $19 billion in healthcare costs. And it's thought that by the year 2025, it will result in up to $25.3 billion in costs each year. So certainly looking at osteoporosis from a preventative standpoint is very important. And last but not least, osteoporosis, like the pink panther, can certainly sneak up on you. It's not like hypertension and diabetes. It's not something that you are going to feel. You can't feel your bones becoming weaker. You could have osteoporosis and without being tested for it, not realize it. And unfortunately, if you're not tested, breaking a bone would be the first clue that you would have. We will speak more about DEXA scans, but a bone density test can help you determine if that's what's going on. So this is kind of just a funny little slide. And I mean, from a purely cosmetic standpoint, losing height and developing what in this case would be called a dowager's hump is not something that, you know, women aspire to, certainly. And osteoporosis from that perspective, you know, from a purely kind of vanity perspective, is something we all want to avoid. So one question is, when should one be thinking about osteoporosis? So let's take it kind of decade by decade. In your 30s, there would be no reason to have a bone density scan at that point, either from a screening perspective or really for any other perspective, unless you have severe risk factors, including being on glucocorticoids, something like prednisone, dexamethasone, for some other type of condition. But beyond kind of these rarer cases, there would be no reason to have a screening DEXA scan at this time. What you would want to do in your 30s is certainly work on prevention, and that includes exercise, especially weight-bearing exercise. What does weight-bearing exercise do? It allows for actually microfractures in the bone, so that it's calling those repair cells to fix those microfractures and allow new mineralization of the bone, allowing for healthier bone. So that's the whole point of the weight bearing. You would definitely want to stop smoking if you were a regular smoker prior to your 30s, because smoking is a risk factor for low bone mineral density. You would want to restrict your alcohol intake to fewer than 7 drinks per week. An alcohol intake over that amount can increase your risk of low bone mineral density. You would want to avoid excessive weight loss, and we're going to talk about body mass index and how that can contribute to low bone mineral density. And your goals for calcium and vitamin D intake, and this is a combination of diet and supplement. So anytime I talk about calcium and vitamin D, keep in mind that I'm not strictly promoting supplementation here. If you have a diet that's high in dairy, such as milk, cheese, yogurt, cottage cheese, ice cream. These are all sources of calcium and vitamin D. You might worry about your cholesterol, but I mean, from a calcium and vitamin D perspective, these are good sources. Leafy green vegetables, high in calcium, and I'm talking here kale, broccoli, spinach, high in calcium, not as high in vitamin D. In your 40s, you may consider a baseline bone density scan, especially if you're perimenopausal. In the year before and the year after menopause, the bone density really drops rather precipitously and starts to even out after that. You start to have more of a slow decline. But in the years immediately around menopause, that's really where you're going to see your greatest drop in bone mineral density. And if you happen to be one of those women who is perimenopausal in her 40s, you may want to consider a baseline DEXA scan at that time. Not that we're necessarily going to discover osteoporosis, but so that we have something to compare it to when you get checked in the future. Again, the same rules apply. You're going to want to engage in weight-bearing exercise, stop smoking if you haven't already, restrict your alcohol, and the calcium and vitamin D goals are the same in your 40s as they are in your 30s. In your 50s, you may again consider a baseline DEXA if you didn't have one in your 40s. You would also have a DEXA if you break a bone. You would have a DEXA if you have risk factors, if you have a family history of osteoporosis, if you have a low body weight, and there I refer to a body mass index less than 19. We'll go into body mass index. If you are a cigarette smoker, if you went through menopause in your early 40s, you would certainly want to have a DEXA scan in your 50s. If you have a history of overactive thyroid, you would consider a bone density scan in your 50s. If you have a history of celiac disease, or you've ever used Depo-Provera for birth control, that would be a reason. If you are on a type of medicine for the mood, a selective serotonin reuptake inhibitor, like Celexa, there are a host of medications in that category. And you would consider having a bone density scan in your 50s with that type of medicine as well. Your goals in your 50s for calcium and vitamin D do increase. Your calcium intake there, diet and exercise, should be 1,200 milligrams a day. And your vitamin D intake should be 800 to 1,000 international units a day. In your 60s, we will talk now about what do screening recommendations say. So everyone over, basically the thought is that in regards to women, women should have a DEXA scan over the age of 65. You would consider a DEXA under the age of 65 with those risk factors that I enumerated in the last slide. And the other thing that you may consider, if you're going to consider having a DEXA scan under the age of 55, if you've had an X-ray showing break or bone loss, even if you don't have those other risk factors, an X-ray showing a fracture, you would get a DEXA scan. If you've had height loss of a ½ inch or more in 1 year, you would get a DEXA scan. And if you've had a total height loss of 1.5 inches from your original height, and truly no doctor is going to know that. No one's going to know that better than the patient. I mean, unless you've had the same doctor really your whole adult life. So that would be something you would have to bring to their attention. And that would also call for a bone density scan. Your calcium and vitamin D intake in your 60s are the same as in your 50s insofar as 1,200 milligrams a day and 800 to 1,000 international units of vitamin D a day. And last but not least, in your 70s and beyond, bone density, there is a screening recommendation for men to have bone density scans if a man is older than 70. Last but not least, all women in their 70s should be having bone density screening. And there's no data right now on when to stop having bone density screening. Generally, insurances will pay for, most medical insurances will pay for a bone density scan on the order of every 2 years. And right now, there's just no evidence on when to stop this. And your calcium and vitamin D recommendations are the same as they were in your 50s and your 60s. So you see here some foods that are high in calcium and vitamin D, although green leafy vegetables less in vitamin D. But dairy products, salmon, sardines, these are the fatty fish, are high in calcium and vitamin D. So one question might be, if I'm looking at a nutritional label, how do I know how much calcium it contains? Well, they don't report calcium in milligrams on a label. They report it as a percentage. And you should know that they are telling you the daily allowance, the percent daily value. They consider the general percent daily value for anyone to be 1,000 milligrams a day. That's what they want your calcium intake. That's the recommended calcium allowance, 1,000 milligrams a day. So if this is reporting that 1 cup, the serving size of this milk, say, is 30%. So if you have a cup of this milk, you're getting 300 milligrams, 30% of that recommended daily allowance, which is 1,000 milligrams. So 30% of 1,000, 300 milligrams is what you're getting from 1 cup of that. And this is what you need to be considering when you're looking at your diet in terms of supplementation. As I kind of mentioned before, the daily value is the standardized measure. It was developed by the FDA, help you learn exactly what specific nutrient is contained in the food. The percent daily value is based on 1 serving, so you do need to account for how many servings you're having of that given food. And again, the daily value for calcium is based on 1,000 milligrams, so it goes on to say recapitulate what we mentioned on the last slide. In the case of vitamin D, the daily value is based on 400 international units a day. This means that food with, say, that says 25% vitamin D has a quarter of that 400 international unit daily value, or 100 international units of vitamin D. And truly, there are very few food sources for vitamin D, which is why if you're going to get it from your diet, it has to be vitamin D fortified, and that's mostly milk. Yes.
What about sunshine?
You're absolutely right. Sunshine is a great natural provider of vitamin D. And in fact, when you trend vitamin D in a patient population, it's amazing how in the summer, most people are sufficient, and then you recheck in November, December, and someone is deficient again. So I will say that if you're going to try to keep an even keel, you probably will need more supplementation in the winter, in those darker months, than in the springtime that we're entering now. So as far as detecting osteoporosis, let's talk a little bit about your medical history and things that might be red flags in the medical history for being concerned about osteoporosis. There are innate risk factors, things that you simply can't change. There are lifestyle risk factors, medications and medical conditions that will put you at risk for osteoporosis. So certainly risk factors that are difficult to change. Age. Osteoporosis is more common with age. All of us will lose bone density as we age, but some people will lose more bone and lose it faster. As far as our gender is concerned, about 1 in 2 women over the age of 50 will break a bone because of osteoporosis. And women have lighter and thinner bones than men. So unfortunately, being a woman puts you at greater risk for osteoporosis. Menopause is a risk factor because estrogen protects bones. And menopause, when you go through that period of time where you're losing your natural estrogen, you are at risk for losing bones as well. The same is true if you go through a surgical menopause. If you have what we call an oophorectomy, if you have both ovaries removed for one reason or another, that's surgical menopause. And from that point on, you no longer have that estrogen protective effect unless you take estrogen hormone replacement therapy. We will talk about that under therapies. If you have a history of a low body weight or being small and thin, actually, I'm sorry, I skipped over family history. There is research that suggests heredity and genetics do play a role in losing bone mineral density. If either of your parents had osteoporosis, you are more likely to break a bone. And in fact, in the tool that we use to assess risk for broken bone, a tool called FRAX, which we will talk about, heredity plays a major role in determining your risk factors for breaking a bone. Low body weight or being small and thin is also a risk factor. And last but not least, if you have broken 1 or more bones during your adult years, so not before puberty, you may already have osteoporosis and not know it. And in fact, a broken bone will put you at risk for osteoporosis in the future. So what are some lifestyle factors, things that can be changed that you do have control over? Not getting enough calcium and vitamin D. Calcium is a mineral that's very important for healthy bones, as is vitamin D. It's important because vitamin D allows your body to absorb and use calcium. And as far as, I think we went over pretty well exactly what your calcium and vitamin D requirements are based on your age. Not having enough fruits and vegetables is also a risk factor because eating a balanced diet is important for healthy bones. Getting too much protein may be a problem, especially diets that are very high in non-dairy sources of protein. This may actually cause you to lose calcium. You'd actually waste it through your kidneys in the urine if you are on, say, a very high protein diet, something akin to like an Atkins type of thing. Very high in animal protein, non-dairy protein, you may actually lose calcium. And the same is true in dietary sodium, if you have a diet very high in sodium or caffeine. Having an inactive lifestyle is a risk factor insofar as not participating in weight-bearing exercise. Yes?
How much caffeine, do you know?
Specifically, no. I don't know to the milligram exactly how much caffeine is a risk factor. Something on the order of a cup of coffee a day, that's not a risk factor. But having coffee followed all day by caffeinated sodas, that is a problem. Drinking too much alcohol is a problem insofar as a risk factor for low bone mineral density. And really, research kind of points to over 1 beverage a day, so over 7 a week, is a risk factor for developing osteoporosis. And last but not least, losing weight is trouble. That will contribute to low bone mineral density, thanks to not having weight on board to act as an additional weight-bearing exercise when you walk. You can think of your own weight as being helpful for building strong bone. There are a number of medicines that can cause bone loss. Anti-seizure medicines are listed there. They're big offenders. Aromatase inhibitors are big offenders insofar as they are limiting your production of estrogen. Cancer and chemotherapeutic drugs are certainly put you at risk for osteoporosis. You'll notice on there Lupron and Zoladex. These are medications that are sometimes used in the setting of prostate cancer, and these can put you at risk for osteoporosis. I mentioned Depo-Provera in another slide. Proton pump inhibitors can inhibit the absorption of calcium from the gut. And I mentioned selective serotonin reuptake inhibitors. There are some other names for you: Lexapro, Prozac, Zoloft. These can interfere with calcium absorption. Steroids can actually cause your bone to lose mineralization. So in fact, even if you have normal bone mineral density, if you are going to be on a steroid, the equivalent of prednisone 5 milligrams for over 3 months' time, it's recommended that you take a bisphosphonate, and we'll talk about that class of medications, even in the setting of a normal bone mineral density. Tamoxifen is a risk factor for, well, especially, frankly, used before menopause. Again, from that estrogen effect. And last but not least, a class of drugs used for diabetes, Actos and Avandia, have been implicated in low bone mineral density. Avandia is all but off the market now, thanks to the cardiovascular effects that it caused. Actos is still on the market, and it was not implicated as much in causing osteoporosis as Avandia, but it is thought to be a class effect. And last but not least, medical conditions. A number of medical conditions can cause bone loss. HIV, bone marrow and blood disorders, certain types of cancer, Cushing's syndrome, an endocrine condition where your body makes too much of its own natural steroid. Eating disorders, especially, certainly anorexia nervosa, where your body mass index is quite low. If young women do not have menstrual periods thanks to working out too much or not maintaining a healthy body weight, this puts you at future risk of osteoporosis. Hyperparathyroidism is an endocrine condition where the parathyroid glands that sit in your neck make too much parathyroid hormone. In normal amounts, it keeps your calcium level normal. When it's overproduced by these glands in the neck, they steal calcium from the bones and can cause osteoporosis. That is a secondary cause of osteoporosis and should be treated separately. Too much thyroid hormone, whether it's taken by pill or whether your own thyroid is overproducing thyroid hormone, big risk factor for osteoporosis. Liver disease, celiac disease, because you're not absorbing calcium and vitamin D in the setting of celiac disease. Parkinson's, polio and post-polio syndrome. Premature menopause is a risk factor. So there are a whole host of medical conditions that can cause bone loss. Yes?
If the prostate cancer, if that is removed, does that cause bone loss?
So the way that causes bone loss, and really if the prostate cancer has spread to the bones, those are lytic lesions. That's not osteoporosis per se. But often the treatment of prostate cancer involves using medications, gonadotropin, releasing hormone inhibitors. So medicines like Lupron. So the very treatment of prostate cancer can cause bone loss.
Okay, but if they remove the prostate completely and there's no other treatment, then that's not going to cause bone loss, right?
That's not going to be as much of a risk factor, no. Especially if they don't need to take any hormone-related therapy, that should not be a risk factor for bone loss. So what is the best way to detect osteoporosis, or what might you expect during a physical exam if you're seeing your doctor for possible osteoporosis? Well, physical exam is important, but it's not going to tell your doctor everything they need to know. But what you might experience is a height and weight, because your doctor will use a calculation called your body mass index to determine if you're at risk for fracture. Usually this is calculated because you have to use your height in meters and your weight in kilograms to determine your body mass index. But in any case, a body mass index less than 19 is a risk factor for fracture. And they will also assess for height loss. But again, some of that's going to be history, because most physicians you're seeing as an adult have not documented your adult height at its top, so to speak. So that's kind of a historical point that you'll want to bring to your doctor's attention. They'll palpate the thyroid for nodules or for what we call thyromegaly, is the thyroid enlarged. The idea there being that it may be a tip-off to test you for too much thyroid hormone with a blood test. They may palpate the spine for areas of tenderness, looking for areas of vertebral fracture. Not that you can feel a vertebral fracture, but the idea being that vertebral fractures often cause tenderness. I mean, for many people who have experienced a vertebral fracture, I understand the pain can be quite severe. And the thing is, it can happen outside of any kind of injury. So, but that may be one part of the physical exam. And last but not least, when a doctor feels for edema or swelling in the shins, that's looking for signs of other types of disease, kidney disease, liver disease. Those would be, far along problems, truly. I mean, if you're having edema from liver or kidney disease, that's a problem. But that's one of the reasons why they may do that. Severe hypothyroidism may also cause swelling in the shins, although hypothyroidism won't cause bone loss. Hyperthyroidism would cause bone loss. So what is the best way for detecting osteoporosis? It's by using a bone density scan, or a DEXA scan, and that's what we'll discuss now. So DEXA stands for dual energy X-ray absorptiometry. It's hard enough to say it on a good day, but absorptiometry. And it's a very non-invasive test. You remain fully dressed. You do lay down on a flat surface on a table, and you may have to, the technician may adjust your legs. They may end up pointing your toes inward so that you feel pigeon-toed. They may use something to adjust your legs so that you stay in that position while the scanner scans down and then up again over your bones. A central DEXA, which is what we're using, something to measure the central bone mineral density, specifically in your spine, your lumbar spine, and your hip, uses very little radiation. If we're going to compare it to something more common, you're exposed to 10 to 15 times more radiation when you fly round trip between New York and San Francisco. When repeating a bone density scan, you've had your initial one, you go back for another one within 2 years, maybe 5 years later, depending on how it looked the first time, it is best to use the same testing equipment, meaning that you should go to the same facility. You cannot use a standard X-ray to determine your bone mineral density. It's not as calibrated. It can show you low bone mineral density. Some doctors, in fact, even in the absence of a fracture, will ask you to have a bone mineral density scan after getting an X-ray, because they can tell from the quality of the bone on the X-ray that it's deprived of minerals. But it can't quantify your bone mineral density. A standard X-ray cannot. So there on the bottom you see a typical bone mineral density and how that report is provided. Now I will tell you that most physicians, I shouldn't say most, but many testing facilities will only pass along the report, which sometimes only contains T-scores, which we'll talk about. That's not an adequate report. Truly, the doctor who ordered the test ideally will receive all of this. And in fact, you may want to ask your testing facility if they are sending the images along with the report. And I say this is important because if you have a dramatic change in your bones from one testing period to another testing period, your doctor needs to make sure that they're comparing apples to apples. You can see where they drew those boxes there. Well, if that box that is crossing the femoral neck, that's crossing the femoral neck. If that box were moved further up, you would have a much higher bone mineral density. So it matters very much that they are positioned correctly. Now, admittedly, the technicians who are doing this know how to position these, but the doctor should always lay eyes on the picture. Furthermore, is the same hip being compared? I've had studies where one year the right hip was done and the next year the left hip was done. Now, if you've had a hip replacement, there's a reason for that. But you need, again, the important thing is that you're comparing the same thing to the same thing. I mean, that's frankly a whole discussion in and of itself, is how to read a DEXA scan. And in fact, there's certification for how to read a DEXA scan. Again, even if your doctor is not certified in reading DEXA scans, it's helpful to look at the images, and they should be provided. So what is a T-score? Many people, when they're talking about their DEXA scans, talk about T-scores. And your bone density results are provided in a measurement of mass, grams per centimeter cubed, but they're also provided as a T-score. And this shows how much your bone density is higher or lower than the bone density of a healthy 30-year-old. Now, this doesn't really seem fair, right? But this is the convention. This is the convention that we use for osteoporosis. The idea being that it's standard deviation. And I think we'll go into that more on the next slide. So what does your T-score mean? A T-score of -1 or above is normal bone mineral density. And again, -1 would be one standard deviation below that of a normal 30-year-old. So what are examples of a normal bone mineral density? T-scores of 0.9, that's a positive, there's no minus sign there, 0, and -0.9. All of those are above -0.1. They're all greater than -1. So those are all considered normal. A T-score between -1 and -2.5 falls into that osteopenic category. So what are examples of those T-scores? -1.1, -1.6, -2.4. They all fall into that -1 to -2.5. And last but not least, a score of -2.5 or below is what characterizes the diagnosis of osteoporosis. So examples of those T-scores would be -2.6, -3.3, -3.9. So really, what is osteoporosis? The definition is 2.5 standard deviations or more below that of a standard or of a normal 30-year-old population, young adult population. The lower a person's T-score, the lower the bone mineral density. So a T-score of -1 is lower than a T-score of +0.5, and a T-score of -3.5 is lower than a T-score of -3. What is a Z-score? Now, I don't know if there will be a lot of interest in this, but if you end up getting a report of your own bone mineral density, you will see Z-scores reported as well. And a Z-score is kind of a fairer assessment. And so, I mean, again, we don't use it for the diagnosis of osteoporosis. However, while the T-score is comparing you to this young adult population, a Z-score is comparing you to your peer. Someone of your age, gender, body size, and last but not least, race. So that none of that is accounted for with the T-score. That is accounted for with the Z-score. So if a doctor is concerned about low bone mineral density in a child, in a young adult, in a premenopausal woman, or in a man younger than the age of 50, they will use a Z-score. And you would be considered to have significantly low bone mineral density if your Z-score is less than -2. If it's over -2, well then you're pretty much thought to still be fine. But if it's less than -2 in that population, that's a concern. I will say physicians will use Z-scores in postmenopausal women when they're concerned about something other than menopause contributing to your low bone mineral density. Because again, menopause is a major factor, menopausal bone loss. That's reason number one for most women to have osteoporosis. But if your Z-score is less than -2, your doctor should also be considering a secondary cause of osteoporosis besides just that associated with menopause. This is a graph that just demonstrates in a picture form what we're talking about here. So that thick line at 0, that's the bone mineral density of that healthy young adult population. So you can see that whereas the dotted line here will follow that normal line. So it's following that normal line up to a point, say, somewhere in the neighborhood of 40 to 50. And then you're going to start to decrease. And this is the trajectory that many people follow. So your T-score is always going to compare you to that young adult goal, mean, whereas your Z-score, let's say if this is your bone mineral density, is going to compare you to that general curve that matches your the other things that make up, again, as we mentioned, the age, the race, gender, etc. So when might you consider treatment for low bone mineral density? If you have a normal bone density, you certainly do not need to take a medicine for osteoporosis, unless there are some extenuating circumstances like being on the equivalent of prednisone 5 milligrams or more for greater than 3 months. That would be a reason. So I say most, and certainly not all, it's never all, most people do not. Some people, when you have a T-score between -1 and -2.5, that's the osteopenic category, may consider taking a medicine for low bone mineral density. But really, there have to be other risk factors that come into play. Definitely other risk factors that come into play in that category. And last but not least, in the osteoporotic category, you really should consider treatment for your bone mineral density. So when you have osteopenia, when you've had a bone density scan come back and your doctor informs you, you don't have osteoporosis, but you have osteopenia, what to do? What's the next step? Treatment is not always necessary, and the way to decide is based on this very well-validated instrument called FRAX. Now, FRAX is the next thing we'll discuss here. It is a tool developed by the World Health Organization. It calculates a person's absolute risk of breaking a bone in the next 10 years. And it provides 2 measurements. It provides your chance of breaking basically a vertebral fracture and essentially non-vertebral fracture. It helps to identify people who have a greater chance of breaking a bone in that osteopenic category. So the use of FRAX. It should be used in postmenopausal women or men age 50 and older. That's what the instrument is designed to address. People with osteopenia and people who have not taken an osteoporosis medicine. That's the type of person that can be plugged into FRAX. Now, some physicians will use FRAX even if you don't meet these criteria, but it's not validated for use in that population. This is the population it's validated for use in. And this is what it looks like. It's literally online. It's an online tool, and anyone can access it. I will say people who treat osteoporosis on a regular basis have this bookmarked so that when you're seeing them in the office or if they go back to their office to do something, they can pull it up and use this. In any case, you can see the kinds of things that it asks. This is not a live screen, but this is exactly what would come up. I mean, if you Google FRAX, this is the first thing you'll see. And you'll be asked to put in your country. Well, actually, first it will ask you your continent, and then it will ask you the country. So it's taken into account studies from all over the world in assessing your risk of fracture. You're asked for age, sex, weight in kilograms, but if you go ahead on the right side and put in your pounds and hit convert, it will convert it to kilograms and plug it in for you. And same thing with height. Put in your height in inches, it will convert it to centimeters and plug it into the box on the left. It will ask you about a previous fracture. We'll talk about that. We're not talking about childhood fractures here. It'll ask you if either parent ever fractured a hip. That is a major, major risk factor. If you are a current smoker, if you take glucocorticoids, again, greater than 5 milligrams of prednisone for greater than 3 months' time. If you've ever suffered from rheumatoid arthritis is on its own an individual risk factor for low bone mineral density. Interestingly, secondary osteoporosis, and again, this is a tool that, again, your doctor may be using, but I tell you about it because I think it's interesting, and you may, if your doctor hasn't mentioned this to you, you may want to try plugging in your own data. But secondary osteoporosis, provided that you are putting something in box 12, it doesn't even use it. So if you know your DEXA, and when it says select DEXA, if you pull that drop-down box down, it's going to want to know what machine. And really, most people who have had bone mineral density scans have had them done on a hologic machine or a GE Lunar. So you may know, if you got a copy of your report, you may know this. If you don't, you can simply plug in the T-score there. That's also an option. When it says under that box, it says select DEXA, it'll say T-score, or it will actually list 3 machines. If you know your machine, great. If you don't, you can always plug in your T-score there. But again, item 10, you don't have to fill out if you happen to have the results of your DEXA scan. So here, this goes into, and it even explains this on the website, exactly how you should be filling this out. The model accepts ages between 40 and 90. The weight and height, we mentioned kilograms and centimeters respectively. The previous fracture, this denotes more accurately a previous fracture in adult life occurring spontaneously, or a fracture arising from trauma, which in a healthy individual would likely not have caused a fracture. So again, a motor vehicle accident resulting in several fractures, that's not what they're talking about really in fracture. They're talking about referring specifically to a fragility fracture. So something that just in a healthy person probably wouldn't have resulted in fracture. If your father or mother had a hip fracture, you would want to enter yes or no. If you're a current smoker, glucocorticoids, we talked about that, the presence of rheumatoid arthritis. Secondary osteoporosis, they don't tell you there, I happen to know this, but they don't tell you there that if you know your bone density scan, they won't even use that variable. But last but not least, if you drink 3 or more units of alcohol a day, and you should, if you have the actual bone density equipment, that would be great. Otherwise, you can simply enter the T-score. So I wanted to mention FRAX. I think it's very interesting. Now I want to touch a little bit on osteoporosis treatment. So factors that your doctor may take into account when choosing your treatment: your sex, your age, if you have not reached menopause, how severe your osteoporosis is, other problems you may have, and last but not least, personal preference based on how these medications are administered. This is a general list of the medication options that are out there. Certainly the giant in this field is the class known as bisphosphonates, and those include medications like Fosamax, Actonel, Boniva. These are certainly medications that you hear advertised very often. Reclast falls into that category, but it's a little unique in terms of its mode of administration, so we'll talk about that. Forteo is a different class altogether that we'll talk about. Prolia is the newest guy on the block, so to speak, approved for use in June of 2010. Calcitonin has been around a long time, but not particularly effective. Avista is useful in some circumstances, especially if you have a history of breast cancer or a family history of breast cancer and don't need that much bone protection. And last but not least, we should touch on estrogen as a treatment modality. So this is from the National Osteoporosis Foundation website, and these are the drugs approved by the Food and Drug Administration, by the FDA, for postmenopausal osteoporosis prevention, because many of these drugs are used for their preventative qualities. In endocrinology, I think we shy away from that. I think in gynecology, they're more likely to promote the use of these as preventative agents. So they are FDA approved. Many of these drugs are FDA approved as prevention. Treatment, and sometimes the dose for prevention and treatment is the same. Sometimes it's different. Furthermore, it goes on to say what drugs are approved in men. Not every drug that is approved in women is approved in men. And this mostly goes on, it's not to say that it wouldn't work the same, but it's kind of a game insofar as what kind of trials did the drug company do, and did they provide enough data to the FDA to allow it to have that rubber stamp. And last but not least, some of these drugs are approved specifically for use in glucocorticoid-induced osteoporosis, and some are not. So bisphosphonates as a class have to be taken after a prolonged fast. That's the type of medicine that your doctor would instruct you to take first thing in the morning on an empty stomach, at least an hour before food, with a full glass of water. The absorption, and why is that? It's because literally less than 1% of that pill you're taking is being absorbed. The absorption is is very, very low. You're not getting good absorption. So that's why you have to optimize the way you take that medication. And furthermore, you do need to have some caution with reduced kidney function. They are contraindicated if your creatinine clearance is less than 30. And that's different for everyone. That's a calculation. So it doesn't go based on a strict creatinine level, which may be something your doctor measures on a blood test. It's based on your clearance. The first medication we'll talk about in this class is Fosamax. That's approved for the treatment and the prevention of osteoporosis. It is a pill, and it can be taken daily or weekly. This is the only bisphosphonate that's currently generic. So it certainly can be paid for out of pocket much more cheaply, and it certainly is preferred by many drug plans over any of the others. In fact, to take some of the other drugs, you now have to have failed Fosamax in order for other drugs to be paid for by your insurance company. This does have excellent data behind it. It reduces the risk of fractures at the spine, the hip, and non-vertebral sites. It increases bone mineral density at the spine, the hip, and prevents bone loss at the forearm. Now, this is data that's out there. I mean, don't get me wrong. But in terms of on a practical basis, can you expect to see increases in your bone mineral density on the bisphosphonates? Very rarely. Very rarely. The data shows that it happens. But can you really expect your T-score to improve? No. Most doctors are just looking that it's not going to get worse, and that if anything, you're going to improve your bone quality by taking these medications, not necessarily your bone quantity. None of these are anabolic. I will only be talking about one agent tonight that is truly anabolic, that truly builds bone. The goal of these medicines, for the most part, is that you won't lose bone. And last but not least, this does have the longest observational study period of time. It's to say it's been around the longest, it probably has. It came out about the same time as Risedronate or Actonel, but the observational studies last longer for Fosamax, up to 13 years. Mm-hmm.
How is it possible, because I had heard that before about Fosamax, that it has different effects at different points in the body, but how is that possible? It prevents bone loss at the forearm, but it doesn't have the same kind of effect in the spine and hip, I guess.
Well, that is, so here's, the way to interpret that is, they had it actually increases, their studies showed that it actually increased bone mineral density at the spine and hip. So that's considered better. And it did not increase bone mineral density at the forearm, but it prevented loss. That's what their studies showed. So actually, what their studies showed is that it had a better effect on the spine and hip, not as good an effect on the forearm. That's how to interpret that statement. But just pragmatically, we don't generally see in any site a big increase in bone mineral density with bisphosphonates. You might have a little bit of improvement. Sometimes it doesn't even qualify as significant for your DEXA machine. But again, most of the time you're looking to just perhaps improve the quality of the bone and then not cause increased bone loss. Yes?
Apparently, there's a danger with Fosamax and Actonel and some of the others now. They're causing stress fractures in the femurs. And most of the gynecologists are taking their patients off of Fosamax, and I was taking it for 11 years. I've had osteoporosis for maybe 12 or 13 years, and I've been taken off of that. Mm-hmm. And I know someone who had stress fractures in both of her femur.
And that's a big controversy, and it's one that I'm going to dedicate a full, in fact, we'll flip through some more of these. It's much of the others are going to show the same data. I'm just being inclusive of all the drugs. But let's get to that, because that's a big controversy. So again, just relying on the studies provided to the FDA, when discontinued, they showed no acceleration of bone loss relative to placebo, but they did note slow but significant bone loss at the hip. And it's recommended at this time that after 4 to 5 years of therapy, perhaps longer for those with severe osteoporosis, a drug holiday of 1 to 2 years can be offered without substantial loss of anti-fracture efficacy. So that is something that's been established, although some people will argue with the data for drug holiday, but most doctors are doing it, but we will get to that again. Actonel, also approved for prevention and treatment of postmenopausal osteoporosis. That pill, unlike Fosamax, can be taken daily. Fosamax could be taken daily, but usually isn't. Weekly, but Actonel can now be taken monthly. And that's been a big plus for this medication insofar as you can reduce how often you take it. It, exactly like Fosamax, reduces the risk of fracture at spine, hip, and non-vertebral sites, increases bone mineral density at the spine and hip, prevents bone loss at the forearm. These observational studies go to 9 years, not the full, 13 years with Fosamax. When discontinued, no acceleration of bone loss relative to placebo has been noted, although slow bone loss may occur. After 3 years of therapy, due to their studies, they're suggesting that a drug holiday up to 1 year can be offered without significant loss of anti-fracture efficacy. And this, I think, is what's glossed over a little bit when people talk about drug holidays, because there is different data for the different drugs. But I think what's the message that's being propagated is you go on it for 5 years and then you take a drug holiday of, well, who knows how long. The data of drug holiday, it's not, again, it's not great. But it's probably something we need to consider. So again, I'll get to that in a moment. And these studies have shown that after 1 year of discontinuation, bone turnover markers return to pre-treatment levels. Reclast is another medication in the bisphosphonate therapy family. It's an IV infusion. It's given 15 minutes once a year, reduces the risk of spine, non-vertebral, and hip fractures, increases bone mineral density at the spine and hip. In the first time, the Reclast is given once a year as an IV infusion. The first time someone receives Reclast, especially if that's the first bisphosphonate you've ever taken, can cause an acute phase reaction in up to 30% of people. This is fever, muscle aches, like you have the flu, like just diffuse myalgias. And these can last up to 2 to 3 days. Doctors who are being proactive before they provide Reclast to a patient will tell you this and recommend that you just take acetaminophen. Acetaminophen is very effective in this acute phase reaction, and in fact, you may want to consider taking it around the clock, starting with your first dose of Tylenol, acetaminophen, before you get the infusion, and just taking it for 2 to 3 days. It's going to make you feel a lot better. But it's not something that lasts, those fever and muscle aches. And in fact, the next time you get the infusion, a year later, you will likely not have it at all. Furthermore, you will be less likely to have it if you have taken an oral bisphosphonate in the past. Observational studies for Reclast last up to 6 years. And as far as indicating when you might come off this and go on a drug holiday, there are no published studies that have evaluated with Reclast when you might consider going on a drug holiday. Boniva, also another member of this family. It can be taken as a pill daily, monthly, or an IV every 3 months. This reduces the risk of fracture of the spine. I just want to point out that it has not been shown to reduce non-vertebral or hip fractures in prospective analysis. So this is, as bisphosphonates go, your top line, I mean, those that we know to be most effective are Actonel, Fosamax, Reclast. Boniva is a step down, because it has efficacy at the spine for sure. It has not been proven to have non-vertebral efficacy. So it's truly, I mean, it's truly not, it's not as good. It's just not as good in terms of studies. Now, if they did the studies now, the truth is they've probably done the studies. That's the truth. And they, you know, and they're not pointing that out to you, that it's not as good, or that it's not better than placebo. So that's the point. I mean, at first, Boniva had a lot of popularity because you could take it as an IV, and we're going to talk about gastritis as a problem with taking the bisphosphonates. But now that Reclast is out as an IV, I don't see the real utility of Boniva. Now, what are some rare events with the bisphosphonates? And this we do have to talk about. The bone, joint, and muscle complaints that people experience. Osteonecrosis of the jaw, very rare, but certainly reported. This, what you brought up as the fracture of the femur, these are called subtrochanteric fractures or chalk stick fractures, like the femur bone literally breaking like a stick of chalk. Esophageal cancer, very rarely reported, and atrial fibrillation. So osteonecrosis of the jaw, what is it? Pain, swelling, infection, possible fracture of the jaw. Your risk factors are 1, taking a bisphosphonate by IV versus oral. If you have a history of cancer, especially cancer that required you to take the IV bisphosphonate. So you had lytic lesions of the bones, and for that reason you needed the bisphosphonate. If you are on glucocorticoids, if you smoke, or if you have poor dental hygiene. These are the risk factors for osteonecrosis of the jaw. It is a very rare risk factor, 1 in 10,000 to 1 in 100,000 patient years. Just so you know, a dental visit is not necessary before starting bisphosphonate therapy. However, if you need oral surgery and you are taking a bisphosphonate, the American Association of Oral and Maxillofacial Surgeons recommend that if you've been taking it for over 3 years, that you stop it for 3 months prior to dental surgery, and then restart it after the bone has healed. But that if you've been taking the bisphosphonate for less than 3 years, that you can have the dental surgery without a problem, without having to stop it, etc. The evidence behind this, I don't know of any evidence behind these recommendations, but I'm just reporting what their recommendations are. Atypical femur fractures. These have been reported rarely. In fact, when it happens, it's a case report. If the doctor is, either willing to write it up, report it to the FDA, et cetera, it should be. It should be reported to the FDA when that happens. But in any case, some cases have been reported, and the mechanism is thought to be very suppressed bone turnover in the setting of prolonged bisphosphonate therapy. The idea being that how do these medicines work? It's by preventing the uptake of bone. It's by allowing the bone to just kind of sit there and not be resorbed. And the problem with that is that it may lead, when taken over a long period of time, to like adynamic bone, old bone that's just been sitting there for a while, and that you're not getting that constant turnover. That's the thought of how long-term bisphosphonate therapy may lead to this problem, and that consequently you're left with bad bone because it's old bone. It's not constantly turning over, and consequently there's a fracture there. A causal relationship has not been formally established, but there is a theoretical concern there, and there have been case reports. Last but not least, actually we may have another one after that, but as far as esophageal cancer is concerned, from 95 to 09, the FDA received reports of 34 patients who received a diagnosis of esophageal cancer while taking Alendronate. Causal relationship has not been formally established, but the FDA currently recommends that bisphosphonates aren't used in patients with Barrett's esophagus, at least not oral bisphosphonates. And last but not least, this is an EKG showing atrial fibrillation. It's an irregular heart rhythm that has a very particular appearance on EKG. There has been a possible connection between IV Reclast and atrial fibrillation, although a causal relationship has not been proven. This is something you would want to discuss with you. If you have a history of atrial fibrillation, you would certainly want to discuss this with your doctor before starting an IV bisphosphonate. So now talking a little bit about that drug holiday concept. There is no consensus right now on how long to continue bisphosphonate therapy. Stopping therapy after 5 years may be reasonable for some women, as there certainly appears to be residual bone density and anti-fracture benefit. The holiday may vary from 1 to 5 years. There literally is just no data. I mean, the data done by the manufacturers of Actonel suggests that you would want to consider a drug holiday after 3 years, but not have that holiday extend for longer than 1 year. The makers of Fosamax suggest that you can start that holiday after 5 years on the drug, and that holiday should probably not be continued for longer than 2 years. But this is all manufacturer data, and I think what really needs to happen are some randomized, double-blind, placebo-controlled trials looking at drug holiday. The problem is it's very hard to do that in the setting, in the bone world, because what are your endpoints? Are you looking for fracture? It's hard to find patients who are going to be randomized to a placebo arm if they're worried, if they're truly worried they're going to have an increased risk of fracture. Are you just looking at bone mineral density? Most researchers don't think that that's a good enough target endpoint, because at the end of the day, what do you care about? Do you really care about the number on the page, or do you care about if you're likely going to have a fracture? Not to mention the number of people you have to recruit for studies like this is immense to be able to show, to have a study that's going to be powered sufficiently to prove your theory. So again, all I can say about the drug holiday is there is no data, and it seems like even at the places that are the forerunners in bone treatment, Columbia comes to mind, that people, Cleveland Clinic comes to mind, that people basically are practicing what they feel is right. There's no great data. Some folks are restarting the medication based on an increase in markers of bone turnover. This is a blood test. There are blood tests and urine tests out there that are used as markers of bone turnover. The idea being that once your markers of bone turnover exceed a certain point, then you should be restarted, because that's a sign that you could be losing bone. There is no data at this point that suggests that the drug holiday reduces the risk of osteonecrosis of the jaw. And again, that's the whole idea of why you'd even consider a drug holiday, that you're going to try to escape these terrible things that can happen if you stay on a bisphosphonate too long, i.e. osteonecrosis of the jaw, chalk stick fractures of the femur. So what are some other treatment options besides the bisphosphonates? And I just want to touch on these quickly. Forteo is an injection given every day. It is truly the only anabolic agent that will actually do what I've mentioned, which is increase bone mineral density. It increases it dramatically in the spine. It has little effect in the hip or forearm. There is a black box warning insofar as when it was being studied in the lab, it did show an increased risk of osteosarcoma, which is bone cancer, in rats. So, but admittedly, it had to be given in very high doses, 3 to 58 times higher than what would be taken by a human equivalent. But as a result, it is obviously contraindicated in patients with an increased risk of osteosarcoma, so Paget's disease, history of radiation to the bone, an elevated alkaline phosphatase level, or high parathyroid hormone levels. And side effects include nausea, orthostatic hypotension, or leg cramps, although those are pretty rare in patients taking this. You can't take it for longer than 2 years. Right now, it's only FDA approved for 2 years. And the bone density does decline quickly once it is stopped, but most physicians will have you on this for 2 years if you really need an increase in your bone mineral density. And then immediately after treatment, start a bisphosphonate to try to prevent that bone loss of the bone that you've just gained. Prolia is the new medication that was approved in June. This is a monoclonal antibody, and this basically decreases the function and survival of those bad cells, those cells that eat up bone, osteoclasts. The truth is, osteoclasts are important in that they eat up bone and then send out markers to osteoblasts that lay down new bone. But this is targeting those osteoclasts. This kind of falls into where the previous medicine does, insofar as you should be at high risk for fracture to use this medication, or have failed or been intolerant of other therapies. This is an injection every 6 months. The previous injection for Forteo was every day. This has been studied up to 6 years. The big side effect with Prolia is infection of the skin, especially skin infections. This may be related to the fact that it is a monoclonal antibody and consequently interfering with your body's natural antibodies to prevent infection of the skin. And when stopped, the bone mineral density did decrease to baseline within 12 months. So this would be another medication that you would use, and then perhaps after you're done using it, use a bisphosphonate therapy if it's tolerated. Yes.
The side effect, how long do you have that side effect? If you get an injection that lasts, what, 6 months? Do you have it for that whole 6 months?
For the whole
skin
6
thing?
months. It's a great point, and is it possible? It's probably possible because those antibodies are present in the circulation, albeit in decreasing titers over that period of time. But it's probably possible. I have no personal experience with this medication. I haven't prescribed this medication because, and I think, some doctors feel that way too. They really would want to see how something plays out over a period of time before they prescribe it. But that's something that has been reported as an adverse event. Yes.
So the Prolia,
Yes.
does a physician give you that injection?
No, that can be, you can actually give that to yourself. It's not an intravenous, it's a subcutaneous.
And the same with the Forteo?
Same with the Forteo, self-injected, like insulin.
Mm-hmm. And with the Forteo, what did you say about the side effects? They could last a long time, or you said they're rare?
The Forteo side effects are that's actually a pretty well-tolerated medication. Nausea, hypotension, so in other words, when you stand up from lying down or sitting down, you feel like that lightheaded, and if you were to have your blood pressure taken, it's low. That's orthostatic hypotension or leg cramps. I will say I do have a fair number of people who, for one reason or another, need Forteo, and it's a pretty well-tolerated medication. The problem is that it's a shot. I mean, that's why otherwise, it's great. I mean, in fact, there's data in the orthopedic literature about it being, like in terms of fracture healing, very beneficial in fracture healing. Just really make you heal faster and with better quality bone after a fracture. Calcitonin, not really used for osteoporosis, honestly. I just want to mention it. I mean, there's no anti-fracture efficacy. It can be given as a subcutaneous injection or a nasal spray. Sometimes it'll be used in the setting of a spine fracture, a vertebral fracture, because it can actually help with the pain associated with a vertebral fracture. It works on the C cells of nerves, but it's not really good for osteoporosis. The nasal spray, you can develop rhinitis and nosebleeds. Evista is approved for the prevention and treatment of postmenopausal osteoporosis and has also been shown to reduce the risk of breast cancer. It's a pill taken once a day, cannot be used in a premenopausal woman, completely contraindicated, and has been shown to reduce the risk of fracture of the spine. But again, kind of like Boniva, has not been shown in the non-vertebral or hip fracture arena to be effective at decreasing the risk of fracture. Also happens to reduce LDL cholesterol. And I just think we should touch on estrogen. It has been approved for prevention of postmenopause osteoporosis. Can be given orally or transdermally as a patch. Increases bone mineral density in the spine, hip, and forearm. But the Women's Health Initiative study did show us that estrogen does increase your risk of blood clot, stroke, cardiovascular events, breast cancer, endometrial cancer, gallstones. So the truth, so obviously there are a lot of bad side effects, but if you need to take it for one reason or another, especially immediately postmenopausally, you can think of your bones as being protected during that period of time. It does, it protects your bones. It may have all these other bad effects, but it protects your bones.